Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Okay, thank you so much. I'm really excited to be here with you all, and I'm really interested in your interest in using long-acting cabotegravir and rilpivirine in a slightly different way than the FDA has approved it for, only because I think we were waiting for these long-actings for a reason. So I'm going to tell you about what we're doing at Ward 86, but I wanted to first start with, I would be curious how many on this call have started anyone on long-acting antiretroviral therapy. 1/3 of us have started. These came out in January 2021. 2/3 of us have not. So this is a good time to talk about it. So to really go over, why we're so excited, let's start with the case. So 38-year-old gay man, this is a man in my clinic. He has HIV. He was diagnosed 2 years ago. He lives with his brother. He actually is from a group, a racial ethnic group, family. He is not comfortable revealing his status. He actually has not been on medications because he does not want to bring that into his house. And he is, and we are very concerned. We'd like him to be on HIV therapies. So we discuss long-acting ART. And this really leads us to the question of, why do we want long-acting ARVs so much? What are all our adherence challenges that we have? We all know this because we work with people living with HIV. It isn't easy to take medications daily. It seemed like they are miracles to have daily oral ART, but not everyone can take it perfectly. There was a paper last year, Grace McComsey, that about 40%, this was a pharmacy refill across the country study, that 40% actually have adherence less than 80% in the United States. And there was a Lancet HIV article that looked across the planet, published last year as well. And really for those on antiretrovirals, prescribed ARVs, the virologic suppression rate is 79% at 1 year, 65% by 3 years. This is not perfect by all means. And obviously we all know this, but there's so many different barriers. It depends on the circumstances, the group that you're in, the population, the country, but a lot of it is stigma. And long-acting doesn't require, of course, bringing in daily orals to a home or a shelter. And then forgetting and depression, and we are having a lot of, in San Francisco, homelessness, substance use, and mental illness. We consider those our 3 major barriers to adherence. And then this is true of PrEP as well. This is not a discussion about long-acting PrEP, but PrEP as well. This is a large analysis in Lancet HIV last year. Really important that 41% of those who start PrEP discontinue within 6 months. And even those who stay on it, suboptimal adherence is 38%. So it's why we've been waiting for these long-actings. I remember we had so many conversations before the long-acting cabotegravir and rilpivirine came out about wanting to use it in kind of a bimodal population. Those who are just tired of medications, but they really can take oral ART, and those who are poorly adherent, and for all those reasons. But the medications were not studied in that patient group of those who have adherence challenges. So if we remind ourselves of the 3 registrational clinical trials that led to the FDA approving cabotegravir and rilpivirine, given either every 4 weeks or every 8 weeks, over the last year, the every 4 weeks regimen was approved in January of 2021, and by March 2022, we had the every 8-week regimen. And these 3 major pivotal trials were FLAIR, which is studied in naive patients, ATLAS in treatment-experienced patients, and ATLAS 2M. And remember, ATLAS 2M is the every 8-week regimen. And the design of FLAIR is very important for us to remember that no one started who wasn't virologically suppressed. The design of FLAIR in treatment-naive patients took treatment-naive patients, first put them on dolutegravir bacavir TC for about 20 weeks, ensured they were suppressed, and then switched over to long-acting cabotegravir rilpivirine. That actually, there was even an oral lead-in period, which the FDA waived in February 2022 in their new guidelines because there was a direct-to-inject arm, so you can go straight to inject. But really, everyone was virologically suppressed. And then the design of the ATLAS study, same idea. Everyone was virologically suppressed. Actually, these were patients who were experienced. All the participants were at least 6 months on a virologically suppressive regimen, And then they were switched over to their every 4-week regimen of cabotegravir rilpivirine. And then Atlas 2M took some of those participants and also had new participants and took it all the way out to giving a higher dose every 2 months, so every 8 weeks. The results of FLAIR and Atlas, look good at 124 weeks. 80% of those in the long-acting cabotegravir rilpivirine arm were suppressed. Remember though that there was virologic non-response, and there also was somehow a very high proportion that didn't have virologic data. And then the Atlas study, there was even higher rates of, these were treatment-experienced patients who were on suppressive ART before. There was a very high rate of virologic suppression at 96 weeks. And then the Atlas 2M results going up to 152 weeks showed the same thing, relatively high rates of virologic success in the every 8-week arm. That's the green and the blue here. But importantly, more failures in Atlas 2M, especially early on, than in Atlas every 4-week regimen. So this is a very important question because it will relate to what I'm going to tell you about our program later. I'm very curious what you think in the updated pooled analysis presented at HIV Glasgow, which is October 26, 2022. What was the 152-week virologic failure rate in the pooled analysis across FLAIR, Atlas, and Atlas 2M? Was it 0.5%, 1%, 1.4%, 2.8%, or 4.5%? And I'm really curious to see what you think. So this is excellent because we have a spread. And I also thought it would have been higher, like 2.8%. It was actually 1.4%. So in these virologically suppressed patients in Atlas, Atlas 2M, and FLAIR at 152 weeks across all of them, the overall rate of virologic failure is quite low. It's 1.4%. Now, importantly, when you fail, you don't fail well. And what I mean by that is this is a kind of summary of all the failures in FLAIR, Atlas, Atlas 2M. And you can see that when you fail, there is the development of INSTI mutations and NNRTI mutations. So even though the rate is 1.4%, these are bad failures. These are concerning failures. And I will tell you, you likely know, the WHO has actually not yet endorsed long-acting cabotegravir and rilpivirine across the planet. And it could be partially because of this concern that if you get an INSTI mutation, you may knock out what we would use first line worldwide, which is dolutegravir. But on the other hand, very low risk across these 12-24 patients. So keep that 1.4% in mind. This is the next question for you. Of the below risk factors for virologic failures across the trials, those 1.4% of 1, 2, 2, 4, which one can you actually get around, circumvent by a different way to give the injection? Is it low rilpivirine trough concentrations? Is it having an HIV subtype, A1A6, high BMI, history of rilpivirine rounds, or low BMI? So this gets to what are the risk factors for failing long-acting cabotegravir rilpivirine? Excellent. So high BMI is what the majority of you said. And there are 3 major risk factors actually for failing therapy. This was an AIDS paper last year, and this analysis was actually updated at ID Week. It's really having a high BMI. What a high BMI does is it gives you low cabotegravir levels. Also HIV-1 subtype A6A1, which there's nothing we can do about. 2 proviral rilpivirine RAMs in the past is a risk factor for failing. Can't do anything about that, but we can actually do something about the high BMI. And the interesting thing is that there was a study at the European AIDS conference last year, and then a paper in the British Journal of Pharmacology that shows that if you give the injection in someone with a high body mass index deeper into the intramuscular space, which means using a longer needle, a 2-inch needle, you can actually get the drug to get in proper space, the intramuscular compartment, spread out, and you get higher cabotegravir troughs. So we standardly in our demonstration project, which I'm going to tell you about next, if anyone has a BMI of about 27 kilograms per meter squared and above, we absolutely go to the 2-inch needle. And that has been pivotal. In fact, there was a patient we didn't use a 2-inch needle in, and he failed. So I really would recommend keeping this in your protocol. And then before I get to the demonstration projects, I do want to remind us that at IAS last year, there was actually an interesting abstract about not injecting in the lateral gluteal muscle, which is how we inject cabotegravir and rilpivirine, but looking at the PK when injecting cabotegravir and rilpivirine in the lateral thigh. And the PK levels looked pretty much the same as they did than when you inject in the gluteal muscle, which has implications for easier injection, possibly even self-injection, and not that kind of privacy, as much concern. So do keep that in mind and especially, for example, we have a few patients who have had gluteal implants. These are transgender women patients. We are happy and fine giving them the thigh because of this PK data. Okay, so why do we have to study, long-acting cabotegravir and rilpivirine in hard to reach populations, adherence challenge populations? Because not only have we been waiting for this, because we need an alternative for these patients, but because essentially 10% of patients in the US are essentially holding 90% of the virus. And we will never get to end the HIV epidemic until we get to that 10% who are no longer virologically suppressed. So what are the real world studies of long-acting cabotegravir and rilpivirine? We don't have that many, but we do have some. I want to ask you this question, because I asked this of Ward 86. This is a very peculiar Ward 86 question. Do we only have ours? And we call ourselves so cool and awesome? Or do we have two? Okay, I'll ask you, do we have 2 demonstration projects, 3, 4, 5, 6? How many little demonstration projects are there out there that have been presented in some fashion about using long-acting cabotegravir and rilpivirine in the real world? Yes, we're so cool and awesome, but actually 6, but it's interesting. They're small. They're not all finished, and some of them are in abstract form. But I do want to tell you about them because I think it's relevant to say, what's all the data we have in real world populations? So this is actually the HIV medicine paper, which summarizes the compassionate use of long-acting cabotegravir and rilpivirine from ViiV. So they actually gave it out before it was approved in a compassionate use way in those often who could not take oral ARTs. So this wasn't a virologically suppressed patient population. In fact, out of 35, 28 were not virologically suppressed on entry. And actually, after a median of 10 months, 22 of 35, only 63% of participants were virologically suppressed. That's not a good rate. That's 37% virologic failure as opposed to 1.4. So this very small compassionate use program didn't bode well for the use of the medication in virologically non-suppressed patients. However, luckily, we have more data than that. So this was presented at ID Week this last October. This is the OPERA cohort, large kind of across the US cohort of people living with HIV on ART, and of adult people living with HIV who received cabotegravir and rilpivirine injections. There was data on 383 participants that they could report on at ID Week. Now, of those 383 on long-acting ART, only 21 were viremic. So it was a very small group that weren't virologically suppressed, but they reported data that 91% of those, or 19 out of 21, did virologically suppress on the long-acting cabotegravir rilpivirine. And then this was a OFID paper from Atlanta, Georgia, very small group of patients, 15. They all were virologically suppressed, and then 13 out of the 15 remained virologically suppressed. One actually had severe malabsorption, and the other one rebounded after originally suppressing. And then there are 2 cohorts that were presented at Glasgow and ID Week, respectively. This is the Carlos cohort. Now, this is actually a study, an observational cohort funded by the drug company. So because of that, they are only looking at this in virologically suppressed patients. So it's a 3-year observational cohort in Germany. All 200 patients that they started long-acting cabotegravir and rilpivirine were virologically suppressed, and the results at 6 months showed an 89.5% virologic suppression rate, very on-time injections, very low rate of missing or delayed injections. Those other studies didn't give us the delayed injections, by the way, or at least the compassionate use. So importantly, it was a 2% virologic failure rate. So that's kind of on par with the virologic failure rate in the clinical trials in a real-world cohort. And then the carousel cohort, which is ongoing, shown at ID Week, is cabotegravir and rilpivirine across European countries, 5 countries, 18 centers. All were virologically suppressed, 87% virologic suppression rate after starting out to month 12 on the long-acting cabotegravir. Also a lot of on-time injections and a low virologic failure rate. They had a lot of people that they didn't have data on. 13% virologic data, but a low kind of less than 1% or 1% virologic failure rate. So looking like the clinical trial so far. So now I'm going to turn to our study, our demonstration project at Ward 86. And Ward 86 is the HIV clinic that I direct here at San Francisco General. It's important to say that we're on our 40th anniversary of the clinic. We opened our doors in January of 1983, so we're really celebrating this month. It's a very big deal for us. And our patient population is what we call hard to reach or hardly reached. And what I mean by that is that we have mostly publicly insured patients, Medicaid or Medicare, 4% are uninsured. And it's a vulnerable patient population, poverty, high rates of poverty. We now have a major mental illness in up to 45% of our patients, 35% use of methamphetamine. There's actually more enrichment in those who are homeless. In those who are homeless, we have a 78% rate of methamphetamine use. And marginal housing is high. If anyone's been to San Francisco recently, not looking good, but really high level of housing difficulties, and marginal housing in our clinic is a third. So we started trying to give out long-acting cabotegravir and rilpivirine about pretty soon after these were approved. And we did it in a very deliberate manner. And what I mean by deliberate manner is I really want to stress that we put a protocol out. This protocol is actually publicly available. You can download it from the Getting to Zero San Francisco site. It's a multi-page protocol. We update it all the time. And we follow our patients in our demonstration project very closely. We meet every 2 weeks and we go over every single patient. We did that from 12 to 1 yesterday. So it is very rigorous in the sense that we follow the patients closely. However, there are no exclusions about being homeless, for example. In our city, only 27% of those who are homeless are virologically suppressed compared to 75% of those who are housed. So we wanted that homeless population in our demonstration project. And so our inclusion, you all know the inclusion criteria of the trials. We just went over them. You really had to be virologically suppressed, no history of failure. You could only have a K103N, which allows rilpivirine to still work. And our inclusion criteria of getting into the demonstration project at Ward 86 was you don't need to be virologically suppressed. You don't need to demonstrate good adherence. You don't need to take good orals before. You can go direct to inject, which the FDA has approved. But no rilpivirine or INSTI mutations, of course, and you have to, and I'll tell you about exceptions, and you have to say that you'll come to clinic for your injection and give us contact information if you don't. And then we meet every 2 weeks, and we hired a farm tech to help us get the injectables. Ironically, it's actually easier to get the injectables on public insurance than it is private insurance. I would be really interested in hear people's thoughts at the ATC, like if you've had difficulties getting them. I don't really know all the reasons why, but Medicaid, it's pretty easy to get them. We meet every 2 weeks with the clinic leadership, with the pharmacists who really help lead this program, with the leadership of our homeless program, which is called the Pop-Up program, which we actually based on University of Washington's MAX program. And we have this protocol and we change it all the time. And I'm going to tell you the results from the first, actually now 138 patients that we have in the study. These are the demographics of the first 100, though. I'll have to tell you about the 138 demographics when I get them together. But this is the first 100 patients that we enrolled in the demonstration project. You could see that mostly cis men, actually, quite a bit of diversity, 37% white, full on 54% have unstable housing in some way. 98% are on public insurance, 39% report current methamphetamine use, and our proportion of on-time injections was 73%. And I think this is very important. We allowed in virologically non-suppressed patients. 41 out of the first 100 are virologically have viremia, and their log 10 viral load mean is 4.22, and 59 were virologically suppressed in oral ART. But you can see the CD4 count of those who are not virologically suppressed. It is so much lower than those who are virologically suppressed because many of these patients really are very advanced in their HIV. And we felt like we needed to give them an option to use the injectables. So these are the results of our demonstration project so far. Of the 59 of those first 100, all 59 who started with virologic suppression, just like in the clinical trials, stayed suppressed. And of the 41 who started out non-suppressed, 98% suppressed It's giving us about a 2% virologic failure rate, but actually they were looking like they were all on their way down. And then this is hot off the press data that I'm going to tell you next. This is the Kaplan-Meier plot that showed that basically at 80% were suppressed by 8 to 12 weeks of those 41 patients who were not suppressed. So it took about, the majority were suppressed by 12 weeks, which is interesting because actually a lot of them were even suppressed by 4 weeks. And then we did project by the Kaplan-Meier plot that 100% would be suppressed by 42 weeks. And the median time to suppression is 34 days. Now, this is what I wanted to tell you is the updated analysis. Literally just got this data yesterday. 138 patients started on long-acting ART at ward 86. Now I can tell you that essentially out of those 138, 40% are not virologically suppressed, 60% are virologically suppressed. And we have had a total of 2 failures. And I mean failures with resistance emerging. Now, if you divide 2 by 138, you get exactly 1.4. So you get a 1.4% virologic failure rate, which is the same as in the clinical trials. And in retrospect, the 2 patients who failed in our program, one had a T97A, which is a minor entity mutation, and one had a V179D, which is a minor and an RTI mutation. We will not allow these in the future. So I really wanted to just give you the latest up-to-date data where we are. We have had really very successful outcomes on using long-acting cabotegravir and rilpivirine in our hard-to-reach patients. These are really complicated patient population, and we are very heartened by our results. And I will end there and get questions from all of you and comments and thoughts. And by the way, we call our program SPLASH, Special Programs on Long-Acting Antiretrovirals to Stop HIV. And thank you so much for your attention.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.